We'll get to the case. Nothing to disclose. So this is a 68-year-old Caucasian woman who initially presented to the Wills ER with about a week of new photopsias in both eyes. On history, she described her visual disturbances as burgundy splotches in each eye. They covered about 50% of her visual field in each eye. They were transient in nature and present for only short periods of time throughout the day. She otherwise denied any eye pain, redness, photophobia, headaches, or floaters. On presenting exam, she was vitally stable. Vision was 20/50 in the right eye, pinhole to 20/30, 20/50 in the left, pinhole to 20/25. Pupils were sluggishly reactive OU, and there was noted to be a trace to 1+ RAPD on the right. Color plates were full in both eyes, but she did report 50% light desaturation in the right eye. Intraocular pressures, confrontational visual fields, and motility were normal. On anterior exam, she was noted to have only trace vitreous cell in both eyes, and at the time of presentation, her posterior exam was recorded to be entirely normal. In the setting of her bilateral visual disturbances, APD, light desaturation, and otherwise unremarkable fundus findings, the patient was actually recommended to have an MRI of the brain and orbits with and without contrast per neuro-ophthalmology, which was read as normal. And she was instructed to follow up in clinic about a week later. So a week later, her vision in the right eye had now declined to 20/80 from pinhole 20/25. Dr. Xu, would you mind commenting on this fundus photo?
Sure, absolutely. So we have a wide field photo in the right eye. Vitreous is clear. The optic nerve is one of the things that we're interested in, but here fundoscopically at this magnification looks normal. The vessels notably looks inferior temporally, like there's sclerosis of the vessels. Inferior temporally and temporally, the macula at this mag looks also normal. Otherwise, peripheral looks good.
Great, thank you. We have the left eye, similarly, vision decreased. We're now 2100.
Okay, so here, vitreous is clear, optic nerve looks grossly normal. What we're seeing with the vessels here, and this is probably the same process in the other eye, but we're actually seeing quite a bit of sheathing of the vessels. This probably represents the veins. It's a little hard for me to be able to tell. It could be arteries and veins, but that's the notable finding there. No hemorrhages, really, except maybe one superiorly I'm seeing.
We have autofluorescence of the right eye.
So yeah, this is going to be helpful for detecting any RPE abnormalities. Nothing significant of that nature right now in the macula or periphery.
I think that it's important to note that you can see this sheathed vessel here crossing another sheathed vessel, so it is arteries and veins.
Nice.
In the left eye.
Yeah, I mean, you can detect here, there's sort of a mottled appearance of the peripheral retina there with the level of autofluorescence.
Okay. We have OCT cuts as well. We have a few here that I'll scroll through. Go back to the original one. What are you noticing, Dr. Xu?
Well, so when we're looking at the cuts, the OCT helps us show that the vitreous is, at least at this plane, relatively quiet. Now, there does appear to be some significant abnormalities of the retinal layer, specifically in the outer retina, where you see that there's really severe ellipsoid zone, outer nuclear attenuation. Moving away from the fovea, subfoveal, it looks relatively more intact. So it's a pretty significant abnormality there.
And what about the left eye?
Yeah, I think that we're noticing a pretty symmetric appearance as far as the retina there.
We have some fluoresceins.
Okay, so we have a fluorescein here at 36 seconds. We have the arterial phase. And what's important is that there's no frank arterial filling defects. That's what we're seeing so far. That's true. It is pretty delayed. That's true. At a minute, it looks like there's some mild, segmental filling defects, maybe nasally. No real diffuse leakage or anything, even at a minute. So here, late at 3 minutes, yeah, no diffuse leakage or anything. That's kind of and no optic disc leakage, no CME, which we already knew from the OCT, but that's important information. And then here in the left eye, we do see some areas where there is actually phlebitis. Let me make sure that those are veins. There does appear to be some mild leakage and staining of the vessel walls. You see that in some areas temporally and in a few other areas as well. And at 5 minutes late. So that's kind of the biggest finding, I think, right now in that fluorescein.
Thank you. Dr. Polito, based on the limited history that we have at this time and the imaging findings, what would be on your differential for this patient's presentation?
So you have a 68-year-old woman who has burgundy, not Pinot Noir, splotchy vision. And she has a arteritis and a phlebitis, and has also outer retinal changes as well as a mild vitritis in the left eye. So what are the possibilities? And no macular edema that I could see. So the possibilities are still infectious, and you go for the low-hanging fruit first, of course. So you look for luetic disease, and you have the possibility of neoplastic, and neoplastic you could consider vitreoretinal lymphoma on your list, especially in the absence of macular edema. And then autoimmune diseases you could consider as well, including lupus. And nowadays, I used to not believe it, but I would put in there COVID-related disease also.
Okay, thank you. So given her pretty remarkable outer retinal findings, our differential included white dot syndrome spectrum disorders, in particular Azor, as well as degenerative retinal conditions like RP and cone rod dystrophy. Also under consideration was autoimmune retinopathy, which includes both paraneoplastic and non-paraneoplastic etiologies. And then we also considered both infectious and inflammatory conditions like sarcoid and syphilis, and potentially medication-related or toxic effects. Is there anything on this list here that you would eliminate now based on the information we have?
Yeah, so again, there is definitely some phlebitis and vascular sheathing. So I think the inherited retinal diseases can be put way low on this list. Medication-related, way low on this list as well. Autoimmune, I still, I think is reasonable, and I would keep that on the list. Azor, fundus autofluorescence doesn't go along with Azor because there's not a trilaminar kind of pattern. So I would drop that down and put autoimmune and infectious a little higher.
And it's not zonal for the Azor.
Right.
What would be your next steps in working this patient up? Dr. Polito.
So you do have a visual field on her and ERG.
Funny that you ask.
So there's no rod. So the first one is the scotopic dim flash, so this is purely rod response, and there is none. The number 3 and 4 are then you put in a very bright flash and excite both the rods and cones, and basically there is no response. Then you have the separate cone. Hold on. The oscillatory potentials are a little down as well. That's kind of inner retina also. Okay, go to the cones then, if you have that separately, or?
This is all we have, actually.
Okay. Well, so the rods and cones are both severely affected. It's almost isoelectric,
Okay.
which is pretty amazing because you wouldn't expect to be for it to be such a diffuse response. This kind of helps you because MAR, true MAR, is a disease of bipolar cells. We had a paper as well as others that showed that it's the TRPM1 on that's expressed on bipolar cells and melanocytes that's reacted to in patients with true MAR, and there you get just a diminution in the B wave in the maximum response. So it's an electronegative B wave, but this rods and cones. Excuse me, you can't tell that. This tells you that the photoreceptors are affected, and whether the inner retina is affected, I think so because the oscillatory potentials are down, but you can't say anything about a low B wave if the A wave is low too.
Great, thank you. So the ERG was interpreted as isoelectric in all conditions, and this was interpreted to be consistent with cone rod dysfunction, as you were saying. We also have a visual field, and you can see here pretty severe global depression in both eyes. Dr. Polito, you mentioned MAR. Is there anything else in the differential that you would add based on the ERG and the visual field?
Well, as I said, MAR is much lower on my list of possibilities because of the fact that it's usually the B wave that's affected because of the bipolar cells. So this is photoreceptor disease, not bipolar cell disease, probably. And so you have to think of things like CAR and Recoverin. But again, you want to rule out the infectious causes because, like I said, you always go for the low-hanging fruit. Other possibilities, maybe vitamin A, but forget vitamin A because you have the mild vasculitis. So that's kind of out of the picture. You just don't see that with vitamin A deficiency. I wouldn't get vitamin A in her then.
Great, thank you. So I've withheld a little bit of history. We learned that the patient actually has a diagnosis of metastatic endometrial cancer and has also recently been started on a medication called pembrolizumab. To delve a little bit further into her oncologic history as they pertain to her presentation, about a year ago, she was diagnosed with metastatic high-grade endometrial cancer after she presented with abdominal pain. And in the ensuing 4 months, she underwent 6 cycles of neoadjuvant chemotherapy consisting of carboplatin and paclitaxel. Dr. Polito, were either of these chemotherapeutics known to be retinotoxic in any way?
So the platinum-based ones can cause, just like they can cause neurologic problems, they can cause some retinal problems as well, but that's rare. Paclitaxel, because it's a taxane, affects the Mueller cells, but you get fundus findings that are very different. You see kind of a non-leakage macular edema.
Thank you. In March, she underwent surgical resection to debulk her tumor, and she had interval imaging, which unfortunately demonstrated progression of her disease, and so the decision was made to start her on pembrolizumab by her oncologist. And about a week later, actually, is when she developed her visual symptoms. Just as background for the residents, pembrolizumab, marketed under the trade name Keytruda, is a checkpoint inhibitor. Specifically, it's a PD-1 receptor antagonist. So specifically, it's a humanized monoclonal antibody that blocks the interaction between the PD-1 receptor, which is present on lymphocytes, and the PD-1 and PD-2 ligands, which are present not only on normal cells, but also malignant cells. So this interaction essentially blocks the downregulation of the immune response and promotes a cell-mediated immune response against cancer cells. It was initially approved in 2014 and has since garnered approval for a number of different advanced oncologic indications. Checkpoint inhibitors as a whole have been implicated in a pretty broad range of ocular side effects, including intraocular inflammation. Dr. Dunn, can you comment on your experience with some of the ocular side effects related to pembrolizumab, and is our patient's presentation potentially consistent with pembrolizumab-associated intraocular inflammation, given the time course of starting this medication and developing her vision symptoms?
So it could be, although that's an early onset. Usually it's after 2 or 3 doses of the checkpoint inhibitors when the uveitis tends to occur, so it's a little bit early on. We're still trying to figure out the manifestations of these drugs because they're relatively new. It could be, there's no way to say. I'd be thinking much more likely that this is cancer-related rather than checkpoint inhibitor-related, largely because of the changes on the ERG. So the vascular changes are not a classic feature of carcinoma-associated retinopathy, but you can certainly see them. The low-grade vitritis can occur. Both of them theoretically could occur with checkpoint inhibitors. But again, I think the ERG is much more suggestive, and the time course is more suggestive of this being primarily a cancer-associated retinopathy and not a checkpoint inhibitor-induced uveitis.
You got to think too, and I agree totally with Dr. Dunn. So you start the checkpoint inhibitor, and within a week you have problems. Well, if we're saying that this is antibody-related, you can't get antibodies that quickly. So pathophysiologically, it can't be from that. Now, can it be a T-cell mediated innate immune response that you could see? Yeah, but that doesn't present with the findings that you showed. It would be more a VKH kind of finding that you can see from checkpoint inhibitors. So just time-wise, this happened from probably giving the carboplatin and the paclitaxel and causing release of a bunch of antigens. And it was at that point that this whole thing started.
Thank you. So at this point, given her metastatic cancer diagnosis and the rest of her findings, cancer-associated retinopathy was highest on the differential. What antibody tests would you send at this point, Dr. Polito?
So there's only one, no, there's 3 that are truly meaningful. Recoverin is definitely meaningful, and if you have a positive recoverin, you've got to look for cancer. Number 2 is CRIMP5, and if CRIMP5 is positive, this is real. And it presents differently. It presents with a lot of inflammation as opposed to this, which is kind of a mild inflammation. And number 3 are obviously the NMO and MOG-related ones. But the others, the enolase, et cetera, even normals have those. This is real.
Okay, thank you. So as you can see here, the patient had an anti-recoverin antibody sent, which was very positive. And she was given a diagnosis of cancer-associated retinopathy. As background for the residents, CAR falls under the umbrella of autoimmune retinopathy, which also includes melanoma-associated retinopathy and non-paraneoplastic autoimmune retinopathy. It was first described back in 1976 by Sawyer when he observed progressive vision loss and retinal degeneration among 3 patients with cancer. Patients typically present with acute to subacute, painless, bilateral, often asymmetric vision changes, typically decreased vision, scotomas, photopsias, and decreased night vision. And as we've seen, fundus findings can be largely unimpressive. And in fact, nearly a quarter of patients can have a totally normal fundus appearance early on. But RPE changes, vascular attenuation, and optic disc pallor have also been described. And as we saw in our patients, there's typically minimal to no intraocular inflammation. The pathophysiology of CAR is thought to be a molecular mimicry type mechanism. There's aberrant cross-reactivity of serum autoantibodies against retinal antigens, and the most commonly associated ones include recoverin, enolase, transducin, among many more. There was a series of around 209 patients that showed that the most frequently associated malignancies were breast, lung, hematologic, and GYN. Most patients are older on presentation. There's a 2-to-1 female to male predominance. And in terms of the timing of retinopathy, it can be anywhere from weeks to years after the diagnosis of cancer, and in some cases can even precede the diagnosis. Dr. Dunn, how would you manage this patient at this time? Her vision is, she was 20/80 in the right eye and 2100 in the left.
So these are really agonizingly difficult decisions to make because typically the treatments that you're going to use for the cancer-associated retinopathy may adversely affect the treatment for the underlying malignancy. So first thing is you have to discuss carefully with the patient and their oncologists the findings and how you want to approach this. To some extent, that may be a function of what the patient's long-term prognosis is. If it's a advanced disease and you're really looking at quality of life as opposed to saving the life, some patients will choose to treat their vision better rather than extending their life by 1 or 2 months. So it's a really, really important discussion to have with the patients and the oncologists. You can try treating locally. Sometimes we'll do that first. We'll do an intravitreal steroid injection and see if you get some response. It's pretty clear, although there are no controlled clinical trials of this being a relatively rare disease, but it's pretty clear that steroids are not a long-term solution. Sometimes they'll get a transient response to either systemic steroids or to regional steroid injections, so you could try that. The data are mixed in terms of long-term response. You list those there. We'll usually use some type of combination immunosuppressive therapy to start. So it might be mycophenolate and a T-cell inhibitor like tacrolimus. There's some increasing evidence that rituximab may be helpful in these patients. Again, there's no controlled studies. IVIG and plasmapheresis are always mentioned. My personal experience of those is disappointing. They have a nice pathophysiologic rationale, particularly the plasmapheresis, but from a clinical point of view, it just doesn't seem to work very well. So I'd probably start with a steroid injection, see if you get some temporary response, and then go, depending again on what the treatment of the underlying malignancy is, probably start with immunomodulatory therapy. Insurance-wise, it can be difficult to get rituximab approved, so at the very least, you typically have to start with conventional immunosuppressive therapy. Some patients will have a better response to CAR than to non-paraneoplastic associated retinopathy. So sometimes the visual prognosis is actually a little bit better in these cases than if it's not associated with an underlying malignancy.
Thank you. So our patient was started on topical steroids. She received an injection of subtenon Kenalog and was also started on oral prednisone under close monitoring by her oncologist. And she was continued on Keytruda. She presented 2 weeks later, and her vision had decreased to 2200 in both eyes. Dr. Dunn, given this poor response to what's been tried so far, what would be your next step?
You could try intravitreal therapy. You might get more of a bang for the buck. If it's okay with oncology to do steroids, you still have to check with them about whether true immunosuppressive therapy is okay. That means you have to look at their underlying labs. Do they have any hepatic toxicity? If you're going to do a T-cell inhibitor, do they have any nephrotoxicity? How's their white count doing on the taxane therapy and all that? From the purely ophthalmologic point of view, the next step would probably be to go to a combination of mycophenolate and tacrolimus.
I mean, I don't know that this is that much worse. There was terrible disruption of the outer retina, so she was dangling by a thread. I don't know how she was seeing that 20/50 or whatever it was. So it could be that you're slowing it down too. I just want to throw that out there.
Got it. Yes. So the decision was actually made to admit the patient to the hospital to undergo plasmapheresis. She underwent 5 sessions of Plex. Her pembrolizumab was held, I think, because they were initially at the time there was concern about whether or not it was at all related to her disease process. She was continued on oral steroids, and then shortly after discharge from the hospital, she was started on infusions of rituximab once she got insurance approval. And she was seen a month later, and vision had improved 20/40 and 20/60. Dr. Zhang, what's the long-term management of these patients? How do you typically counsel them on their long-term visual prognosis?
So again, it's a rare disease. There's no controlled clinical trials with rituximab. If there's no oncologic contraindication, they're probably going to be on that rituximab forever. And again, with her underlying cancer diagnosis, forever might not be that long.
This is a paper that was published in AJO recently as a retrospective interventional case series of 33 eyes in patients with autoimmune retinopathy that were treated with rituximab. The study found that over 3/4 of eyes had stable or improved vision after starting rituximab, and there was a statistically significant rate of visual decline that was less after starting rituxan as compared to before. But again, as you said, no good randomized controlled trials supporting use of rituximab in this population. So our patient to date has completed about 4 infusions of rituximab. She remains on her oral prednisone taper, and oncology decided to resume her pembrolizumab to treat her underlying malignancy. Her most recent follow-up, her vision in the right eye was 20/30. We have an OCT. Dr. Polito, are you seeing much changes compared to her initial?
So the inner retina appears somewhat thinner. Whether that's good or bad, it's difficult to know. And one is starting to see more of the laminations in the outer retina. And again, before up here, this is kind of like clouds, and it's all very nebulous. Down here, you're starting to see the laminations, and initially, if you were to show me this, you would say, well, this looks pretty bad, but at least you're starting to get a few, you can start seeing the outer outer nuclear layer here, and which you could barely see before, and you can start to see maybe some photoreceptors that are trying to come back, and here's almost the ISOS right here. So it is a little better.
I think from a functional point of view, your visual field is probably going to be the most helpful way of assessing response to treatment.
We don't have, unfortunately, updated visual field data on her, but the left eye also improved to 20/50 at her most recent visit, and similar changes on OCT.
Yeah, and again, here, you can see the ISOS just goes away, and here's the outer nuclear layer, and it dives away. Here, the retina is much thinner, for good or bad, but you are starting to see outer nuclear layer, and here's a little bit of ISOS starting to regenerate.
Great, thank you. So just some quick summary points. CAR is a rare neoplastic syndrome associated with progressive retinal degeneration. Patients typically present with acute to subacute bilateral, often asymmetric vision changes with a largely unremarkable posterior exam. Diagnosis, as we've seen, involves integration of symptoms, multimodal imaging, ERG fields, and serologic testing. And treatment often requires usually combination immunosuppression, as was seen in our patient. These are my references, and thank you to Dr. Suarez for this case. And without further ado, Dr. Peters will present our image of the week, which is now returning.
Great. I had a quick question for JP and Jose about the burgundy spots. Like, I'm always thinking photopsias immediately go with autoimmune retinopathy, because if it's not a PVD or something like that. You think just any type of funny visual color or light should also raise that red flag? And I know you commented on burgundy versus Pinot Noir.
I think anything that tickles the photoreceptors, you're going to see that, and syphilis tickles the photoreceptors and is probably much more common. And anything that affects it, you're going to get problems more with blue-yellow than red-green, because there's a lot less blue cones than there are red and green cones.
Okay, well, it's been a long time, but Image of the Week is back. This week comes courtesy of Sarah Amanula and Consult Rounds. We have a woman who had a long-standing lid lesion, saw the shields multiple years prior, and then elected to not undergo any treatment. So kind of in a more comfort care scenario, but the lesion had grown significantly, kind of became more fungating, and then she finally sought care. So this is a lid melanoma that has spread extensively, ended up needing extensive resection and enucleation with the shields.
Like a third world. Yeah.
Hi everyone, my name is Kat. I'm one of the second-year residents, and I'll be doing our second case today. I have no financial disclosures. I'm not going to discuss any off-label use and/or investigational use in this presentation. So to start off, just some very general history. We have a 23-year-old woman presenting to the WER with bilateral red eyes and blurry vision. Her visual acuity pinholed to 20/40 OU. She was farm dilated upon arrival, so unfortunately we couldn't check for an APD. Color plates are 0 out of 8. This is like an older record. Unfortunately, I wasn't clear if that meant she wasn't able to even see the test plates, or if this was just like the color plates that she couldn't see. Unfortunately, there was no record of the IOP at this visit. Her visual fields and EOMs were full. On anterior segment exam, she was noted to have diffuse injection, OU, a little worse on the left, significant cell and flare in both eyes, and some pigment on the anterior lens capsule in both eyes. Dr. Polito, this isn't the best quality picture, but would you mind describing what you see here?
So it's a hazy view of the fundus. The disc appears swollen, and I can still see the vessels. The disc appears to be swollen, and I can still see the vessels. So this is Friesen 2, I think. You can see that there is a circumferential line over here where the photoreceptors and retina has been kind of pushed to the side by the swollen disc. The veins appear to be somewhat dilated, and then attention is drawn to the macular region where one can see retinal striations consistent with macular edema. And that's basically what I can tell from this.
Great, thank you so much. Anything else or different you see different here on the left eye? Or pretty much the same?
Pretty much the same. Here, the striations go really far out. This, there's a lot of macular edema here.
Okay, great, thank you so much. So what was recorded for that visit is she did have 1+ vitritis, OU, 360 disc edema, and she was noted to have serious choroidal detachments in the macula, OU. So again, this is a 23-year-old woman coming to the ward. Her main complaint is just that both her eyes have been red and blurry recently. Just with this very limited information and what we've seen so far on exam, what would be your differential, Dr. Polito, and what next steps would you want to take?
So she's young, so we don't have to worry about, we put much lower on the list cancer-associated diseases, and we put higher on the list infectious, and still keep the autoimmune up there. So you always go for the low-hanging fruit, and you put infections first because those are the easiest ones to treat. So Louise, and then for and cat scratch disease, you want to put up there because the discs are swollen, though there's no labor stellate changes. And then for autoimmune, you put in there, she's 20, in her early 20s, you put in there, and snowbanks. Snowbanks are present?
No, just the 1+ vitritis, but no snowballs or snowbanks were
Oh, no
observed.
snowballs or snowbanks. Okay. So that puts way lower on the list things like pars planitis, but I would put there sarcoid, and she's in the right age for lupus, so I would put lupus there as well. Though lupus usually doesn't give you vitritis, it's more of a vasculitis. So.
Great, thank you so much. So at this point in the ward, she was thought to have panuveitis. So just generally for the residents, you know, there are very varied causes of panuveitis that can be broken down into categories. The first one being inflammatory causes, for example, from an exogenous infection like some sort of perforating wound or ulcer, secondary infections that have spread to the uvea from other parts of the eye, endogenous infections like Dr. Polito mentioned that could be, you know, bacterial or viral or protozoal in nature, and then of course immune-related diseases such as Behçet's, VKH, sarcoidosis, and even sympathetic ophthalmia. So then, you know, moving on from inflammatory, we have possible neoplastic causes such as intraocular malignancies and some systemic hematological malignancies. These can present similarly to panuveitis, the so-called masquerade syndromes. And then there are traumatic causes from either trauma or intraocular surgery. But this lady does not just have panuveitis, she was thought to have bilateral panuveitis, which changes the differential somewhat. So we can rule out some things. More likely to be, for example, maybe an endogenous infection or immune-related, less likely to have, you know, bilateral intraocular malignancies, but maybe a systemic one, and then less likely to be traumatic. So the highest on the differential at this point, considering the bilateral nature, was thought to be something inflammatory, such as sarcoid, Behçet's, or VKH, or something infectious, maybe syphilis or bilateral ARN. So a little more history. So she is 23, she's Hispanic, she's complaining of this red eye and blurry vision. Specifically, she's saying my left eye started off first, 9 days ago, started becoming red and blurry. Then my right eye followed just 2 days later. She has no significant past ocular history. She is obese and has GERD and a history of 2 C-sections, otherwise healthy. She's just on some oral birth control. She's had these headaches recently, so she's on Furoset with codeine PRN. She presented to an outside provider who started her on like Suloxone drops for her red eyes. She has no pertinent family or social history. And as far as review systems, as I said, she has this eye redness, this blurry vision, this persistent headache, but she's otherwise well. She specifically denied any known history of ocular infections or trauma, denied any recent Viren syndrome, no fevers, chills, or neck pain, no tinnitus, no vitiligo, no poliosis. Labs and some imaging was done, CBC, CMP, Bartonella, Quant Gold, RPR, ACE, Lyme, and a chest x-ray was obtained. She was started on prednisolone, Q1 hour OU, atropine BID OU, and told to follow up closely with retina, which she did 2 days later.
Go back one. And when you say RPR, it was RPR and specific syphilis tests, right? I mean, you're going down the road of VKH, but you got to rule out RPR is insufficient because it's a non-specific syphilis test.
Okay. I'm not sure, to be honest, at which one. I think it was RPR, and then maybe it reflexes back to like FTA ABS if it comes back positive.
And that's the old algorithm. And unfortunately, there's still some outside labs that use the old algorithm.
Okay.
The new algorithm is specific syphilis test, followed, and this started changing in 2016, followed by the non-specific RPR if the specific test is changed.
Okay.
So if this was done through the ER here, they would have done the reverse algorithm, which would start with a specific syphilis antibody.
Okay.
Then they would look at for an RPR to titer if it's positive, and then they would do an FTA as well.
Okay.
Yeah, believe me, I've argued with some of the outside labs because they're still using the old algorithm.
Okay, great. So she did present to retina 2 days later. Her vision had worsened at this time, 20/80 in the right eye, 20/200 in the left eye. Her IOP was checked at this point, was normal in both eyes. Her exam was pretty consistent with what it had been 2 days prior, still injected, still with a good amount of flare, still with the pigment. Her posterior exam was likewise pretty similar to what it had been 2 days prior. Do you mind just describing what you see here on these OCTs of the right and left eye, Dr. Polito?
OCT of the right eye shows it's hazy. Is this real, or is this just because of artifact? But are those cells there, or is this just a poor quality OCT?
I think some of it might be cell and some of it might be artifact, but I think that she was
And
noted
there
to
are
have cell.
probably cells here on the inner surface of the retina. Then the normal laminations are poorly visualized on this. Probably there might be some infiltration there, but overall you can see the laminations. I would have expected a lot more macular edema or cystoid spaces than what I see here. This is after treatment, or?
This was after 2 days of Q1 hour prednisolone.
Okay, so that's all.
Yeah.
The outer laminations can be seen pretty well. ISOS can be seen relatively well. And then the attention is drawn to the choroid, where first you can see that you don't have a flat line here. So there's some choroidal folds, and you don't see at all the normal choriocapillaris or outer layers of the choroid, because it's all infiltrated and very hyperreflective. In the left eye, here you're drawn to the bacillary detachment over here. There's a small retinal detachment as well with stalactites because the photoreceptors are separated from the retinal pigment epithelial cells and so can't be phagocytosed. And then again, it's a very irregular boundary between Bruch's membrane and the retinal pigment epithelium because of the marked infiltration of the choroid.
Thank you very much, Dr. Polito. And Dr. Dunn, we also did get FA of this patient at this visit. Would you mind walking us through what you see here?
So I'm surprised, given the findings in the left eye, that the FA is not more striking. The retinal vessels look pretty good there. There's less disc staining than I would, or disc leakage than I would have expected. You can see some, looks like some vascular sheathing.
These are ICGs, right?
I thought they were FAs.
Yeah, you can see the choroidal vessels there. And there's some patchy areas of hypoperfusion. You see especially nasally in the right eye and within the macula in the left eye. So those dark hypocyanescent spots would probably fit what Dr. Polito is describing as the abnormalities in the choroid. But it's kind of non-specific there.
Okay, great. Thank you very much. So by this time, some of her labs and imaging had come back, all normal, what had returned. So given the fact that she's still pending a lot of infectious testing, Dr. Dunn, would you be comfortable starting systemic steroids at this time? And if so, would you go with PO or IV steroids?
So for the first question, yes, I'd be comfortable starting it. I think this really strongly suggests VKH, given the clinical pattern and her age and her ethnicity. So I'd be fine doing that. You'll get a faster response to IV. This would be a patient that admission for 3 days of pulsed IV, solumedrol, or methylprednisolone would be reasonable, followed by high-dose oral steroids.
Great. So she was started, I guess maybe she declined or we didn't decide on the IV, but she was started on 60 milligrams of PO prednisone with accompanying vitamin D and calcium, tapering to 50 milligrams after a week. Her prednisolone drops were also tapered to Q2-hour OU. She was asked to return a couple of weeks later, at which time her vision had improved back to what she had been in the WER, 20/40 OU. Her IOP was now elevated, 27 OU. Her anterior segment exam was improved with now just rare cell OU. And her DFE had improved as well, especially in regards to the disc edema OU. And her OCT had improved as well. However, as I mentioned, her IOP had increased from 17 and 18 to now 27 OU. This was presumed to be a steroid response, and she was started on dorzolamide timolol OU, and attempts were started at this point to slowly taper off her PO steroid and prednisolone. Just to summarize the next couple of weeks or months in her course, all of the remaining labs did come back normal. Presumed diagnosis of VKH was made. 6 weeks into her taper, at which time she was on 5 milligrams of PO prednisone and was 1 week off all prednisolone drops OU. She presented to the WER with worsening irritation, photophobia, blurry vision. So her PO pred was bumped back up to 40 milligrams, and she was restarted on prednisolone QID. However, at that WER visit and then following retina visits, her IOP remained elevated OU, mid to high 20s OD, high teens and mid 20s OS. Supramonidine TID and latanoprost QHS was added OU in addition to her dorzolamide timolol. Dr. Dunn, what are your thoughts on using latanoprost in this situation, given, of course, her uveitic history?
So I think the risk of prostaglandin-induced uveitis is actually very low, and I think it can occur. I think the proof is in the pudding. So if you put a patient on latanoprost and the uveitis gets worse, then you can always consider stopping it. But I think the risk is low enough and mild enough that I will always use a prostaglandin in a patient with uveitis and glaucoma before I consider some other sort of intervention, for example, surgery. So I'm fine adding latanoprost here.
What happened to her headache, by the way?
It's actually not noted in the record what happened to her headache, unfortunately.
Let's just assume it got better, and you helped her in that regard too.
Mm-hmm.
Hey, JP, the response to steroids is usually quite good in these patients, but I'm a little surprised at the rapidity of the taper. In my experience, they have to stay on pretty significant doses for quite a period of time. Would you agree with that?
In general, yes. Depends obviously on their clinical response and the side effect profile for that individual patient. But yeah, these patients may need oral steroids for 6 months or so.
Normally,
or
they
transition
respond
to
really well, and so there's great excitement and you want to get off, but they almost always rebound if you taper rapidly, is my experience.
That's a great point. Thank you. So at this time, after she flared, the taper was tried to be slowed down even more. However, even with a taper of PO Pred over 4 months and a very slow taper off her drops, she did flare again. Meanwhile, she presented to an outside provider with IOP of 35 OU. The outside provider added 250 milligrams PO acetazolamide BID to her glaucoma drop regimen. And then she was referred to glaucoma for further management of her ocular hypertension. So at this point, just to remind everybody, she is on dorzolamide temolol BID, brimonidine TID, latanoprost, QHS, and the PO acetazolamide. She's also for her uveitis on prednisolone Q other day, and she's off all PO Pred at this point. Her vision was 20/30, 20/40. IOP was 19 and 18. Gonio showed her to be D40F OU. No PAS was noted. AC was deep and quiet at this point. Cup to disc was noted to be 0.35 and 0.5. Dr. Lee, if this patient had presented to you at this time with this history, how would you have proceeded?
So I think the gonio is critical in these patients with uveitis, because pressure elevations from uveitis can happen for two reasons. It's either direct, where there's direct inflammation to the TM, or there's debris or PAS that forms at the TM, or it's usually indirect, where it's more steroid related. So in this case, the patient has a pretty clean gonio. It's more likely to be mostly steroid response. In these patients, you can be a little bit less aggressive. There have been several studies that show that even SLT works really well in patients with pressures over 40. So you can even consider doing something like that. And a patient that will require long-term steroids, SLT is probably not the best option. The effect will wear off. Mm-hmm. So in those patients, we tend to go more for an angle-based procedure, like a goniotomy or a GAT, where we are bisecting the trabecular meshwork 360 degrees. So we think about it more mechanistically. I mean, if it's a direct issue and there's inflammation actively happening in the TM, we try not to touch the TM, so definitely no laser, no cutting. In those patients, we're more likely to do a tube shunt,
Okay.
or at least for me.
Going back to what Dr. Vander said, you've already shown that she can recur, her VKH can recur. She's now off PO prednisone and on no systemic immunosuppression. How far out is this from
This
initial?
is almost 1 year, but not quite.
Okay. Dr. Dunn, what do you think at this point in a person who's already had recurrence? Would you have her on no immunosuppression at all or not?
Yeah, I think immunosuppression would be reasonable, but she's well controlled on just an every other day regimen. So I'm not sure there's an urgency for that. I think if you're considering surgical intervention, you could argue that you ought to have her on immunosuppression to maybe reduce the risk of postoperative inflammation. But if glaucoma weren't an issue and she had this clinical presentation here and she was controlled with just every other day steroid drops, I'd probably give her a chance on that.
Great. Thank you all so much for your thoughts. So it was decided at this point that a target IOP was set at 23 OU, which she was meeting at this point. So the decision was made to just monitor her at this point with just OCT and continue on all of her medications. Meanwhile, in retina, patient continues to flare on her lower doses of prednisolone every time it's sort of tapered off. And about 1 year after her initial presentation to the WER, she was started on methotrexate, 15 milligrams PO once weekly with accompanying folic acid. while attempts were continued to be tried to made to taper off. So you already started talking about this a little bit, Dr. Dunn, but would you tell us a little bit more on just like how you make your decision on when and to start immunosuppressants?
So some people will treat with concurrent immunosuppressive therapy when the patient first presents and treat them with aggressive steroid therapy on the principle that it's going to take a bit of time for the immunosuppressants to kick in. And then as these steroids are tapered down, you've already got coverage there. Depends a little bit on the patient's underlying medical problems. If they've got diabetes or high blood pressure, it's going to have an impact on how you treat with steroids. If they've got underlying hepatic or renal disease, it may influence how you treat with immunosuppression, how compliant you think the patient is going to be with immunosuppression. So there are a lot of factors that go in. I tend to treat with oral steroids first and see how they do. And as Dr. Vander said, you typically have to treat with long-term oral steroids for this. You can't taper as quickly as you might with some other ocular inflammatory conditions. And then if they get another flare-up, then I would go to immunosuppression.
Great. Thank you so much, Dr. Dunn. So soon after this, unfortunately, she presented back to the WER, again with elevated IOP 43 and 35. She was symptomatic, had eye pain and headache for the last 4 days. She did report that she was reliably using her glaucoma regimen, and she was able to be brought down to 29 and 30 at the WER and was symptomatically improved. So at this point, how would you proceed, Dr. Shukla? She's now spiking again, despite sort of like max regimen.
Great. So since she's had multiple episodes of inflammation since we last gonioed her, I recommend taking a look at her angle again to see if there's any evidence of PAS or any scarring in the trabecular meshwork at this point. If the TM looks relatively clean, I think we can proceed, as Dr. Lee suggested, with a potential TM procedure. Great. So it looks like her pressures are still elevated, gonio's nice and open, no PAS, and her cup to disc has progressed a little bit. So it looks like her glaucoma is getting worse in the setting of these IOPs, which is not surprising. Given that she's a young person with a clean gonio, we want to try to minimize, maximize the real estate that she has available in her eye. So she's someone who has an inflammatory disease that's requiring kind of chronic steroids. So she may have repeated bouts of elevated pressure. So first, I'd recommend starting with a trabecular meshwork procedure, as you guys did, and then in the future, this saves room for potential tube shunts that she may need. I think as you did with the omnigoniotomy, that's a great idea, and then adding on the additional class of medication to try to lower IOP until surgery all makes sense.
Thank you so much. We're going a little short on time, so I'm just going to go through a little quickly. Basically, an omnigoniotomy for the residents is a type of MIGS, or minimally invasive glaucoma surgery. It achieves IOP reduction by restoring flow through the physiological, conventional outflow pathway rather than by bypassing it like a filtering surgery. And specifically, it allows for viscodilation of Schlemm's canal and the collector channels, along with goniotomy, and is less invasive than filtering surgeries. So her course in summary, now she's status post goniotomy OU and she's on the same drop and PO Diamox regimen. Her IOPs did drop to mid to high teens on Q day pred forte. Dr. Lee, is this sort of result you would expect post-Omni in this patient, or would you expect more of a response?
Pressure of 15 on, I'm sorry, how many drops is she on?
She's still on the dorzolamide timolol, the brimonidine, and the latanoprost, and the PO acetazolamide.
15 would be sort of the average of what you'd expect after a goniotomy like this.
Mm-hmm.
Of course, the numbers can go even lower, all the way down to episcleral venous pressures, which is around 8 to 10. But in my experience, usually 15 on 1 or 2 drops is to be expected. The patient, in her, she's on basically all the drops. So I'd assume that there is some level of resistance in the downflow pathways, like the collector channels. So this is somebody I'd watch carefully. She may eventually need a tube shunt if the pressure starts to go up.
Okay, great. Thank you so much. So we've sort of caught up to the present day now. The patient is still being maintained on 15 milligrams weekly methotrexate and folic acid, and she was slowly tapered off of all of her prednisolone. And at the most recent visit, she's now developed 1+ PSC-OU, which is impeding her vision. So she is now planning for cataract surgery. And just really quickly talking about BKH for the residents, it is a bilateral granulomatous panuveitis, commonly affects younger adults in their 20s to 50s. It can have extraocular manifestations, and there's a predilection to people with more pigments, such as Hispanics, Asians, Native Americans, Middle Easterners. There is an association with HLA-DR1 and HLA-DR4, but checking for these is not usually used to make a clinical diagnosis, an aid of the clinical diagnosis of VKH. And the exact pathogenesis is unknown, thought to be possibly a T-cell mediated autoimmune reaction against antigens associated with melanocytes, melanin, and RPE. There are 4 stages: a prodromal stage, which is similar to the viral illness, lasts a couple of days, which then develops into a uveitic stage, which is when they develop blurry vision. Can be monocular at first, so usually very quickly involves the other eye to become bilateral. Then develops into a chronic or a convalescent stage, which is generally when the patient develops symptoms like vitiligo, poliosis, depigmentation of the choroid. This can start several weeks after the uveitic stage. And then the choroidal depigmentation lags behind, occurring months afterward, and this leads to sort of the classic sunset glow fundus, which can be seen. And then recurrent, which is exacerbations of the anterior uveitis, which can be very refractory. So majority of the cases are diagnosed based on clinical findings, but on fundus FA, there's a sort of classic starry sky appearance, which this patient didn't have, but is due to leakage at the level of the RPE and multifocal late pooling. So as we discussed previously, oftentimes in the acute phase, it's treated with IV high-dose corticosteroids, followed by high-dose oral steroids with a very slow taper and immunosuppressants. And this is just a study showing, as we discussed, that patients really need to be kept on steroids for a long period, and that patients who were treated with less than 6 months of steroids had a much higher risk of recurrence and worse visual prognosis in patients who were kept on steroids for longer than 6 months. So it's basically to summarize, this young Hispanic lady came in with bilateral panuveitis, diagnosed with VKH, however, continued to flare with attempts to taper off her steroids, and also developed ocular hypertension in response to the steroids, but responded reasonably well, though not entirely to the level maybe we'd hope with the goniotomy OU, and is now maintained well on her methotrexate, and most recently was added back on the Q-Day Pred Forte and is preparing for cataract surgery at this point. Here are my references. Thank you guys very much for my presentation.